Now it's my pleasure to invite Dr. Mo Yin to deliver the opening remarks. Dr. Mo Yin is the Deputy Director of Advanced ID at Salisbury Hawke School of Public Health, National University of Singapore. Over to you, Dr. Mo Yin.
As many of you may already be familiar, Advanced ID is a very active clinical trial network that has now over 100 hospitals in our registry, working very actively with us across the world, especially Asia and especially in low-middle income countries. So far, in the past, just a short span of 3 to 4 years, we've enrolled over 11,000 patients. And so far, we've been focusing on antimicrobial resistance as the main focus. And we work from a variety of research angles, from more of discovery for newer antibiotics and diagnostics to very applied science in terms of implementation and qualitative methods. We do a lot of trial simulations on innovative designs. We test out newer and existing antibiotics, diagnostics, and prevention strategies. And we also work very closely with international partners, including funders and WHO and other NGOs. So what we focus on, like I mentioned, is antimicrobial resistance. And when we talk about antimicrobial resistance, it's always very complex. When resistance genes and bacteria, viruses, they are all in our environment. So what we choose to focus on is in the hospitalized patients, because these are the patients who really suffer from morbidity and mortality from resistant infections. So for the first project, we did this surveillance study called ACON-HAI that's concluded recently for the first phase, where we enrolled over 10,000 patients. And following that, our first trial was a rapid diagnostic trial, which cuts down microbiology reporting from 5 days to just a few hours and see if that leads to reduction in deaths for our patients. And also at the same time, we started a Asia-wide program to improve diagnostics across the region. Also, we're looking at prevention of infections by cleaning the ICU to see if we can reduce healthcare-associated infections. And also, we are actively recruiting new study sites for 3GNB, which is a platform trial that targets gram-negative bacterial infections. So there's a lot of activities going on in Advanced ID. And the gap that we always felt when we design our studies and implement studies and disseminating results is that we do not involve the community enough. And why is it important to involve the community? So the current status quo is that very few trials actually benefit the patients. This is a review that was published recently in the BMJ Research Methods, that a lot of the trials are actually not published in the first place, and a lot of them did not go through peer review. And out of those trials that end up being published, only those in yellow that end up in a peer review journal or in a guideline. And I think this creates a lot of waste. Essentially, all these trials are either supported, a lot of them supported by academic institutions or national funders. And these are essentially people's efforts to accumulate this wealth that go into clinical trials. And the results of these trials should eventually benefit the community. And a large part of the reason why is there's a severe erosion of trust between the scientific community and the wider public. As we can see during the pandemic, the COVID pandemic, there's a lot of vaccine hesitation, especially in the Asia area and some of the countries in the West as well. And I cite this example here with the dengue vaccine, especially in the Philippines, as in the very recent past, that has eroded a lot of this public trust in scientific research, especially in clinical trials. And the third reason is also that there's a lot of misconception around the motivation behind clinical trials. Of course, we all know that there's investigator-initiated trials and also private company trials. And a lot of companies, they are conducting trials for profit reasons. But however, a lot of actually even for company-driven trials, a lot of the trials are actually conducted because there's motivation to drive science forward and benefit the community. But that messaging sometimes is lost along the way. And of course, across Asia, we have very diverse cultures, religions. We have a very different geographical and political landscape with a lot of different colonial past that has also contributed to the difficulties in communications and in involving the public in research. So sort of why we really want to focus on clinical trials and involving the community is that it is really the gold standard to guide clinical practice compared to observational studies or other kind of simpler kind of methodologies. And in our research, in our program here, we are not limited to antimicrobial resistance, we are not limited to infectious diseases, but we are here to talk about all clinical trials. And we really believe that trials should be done by the people, for the people, and the public should be the greatest advocates for clinical trials. And we hope to involve the community in not just the design, but also in the participation, the analysis, and dissemination of results. So we have our activities planned over the next 3 years. We have already set up the hubs, what we call hubs, or the center of activities across Asia, led by these 3 really capable and experienced people in Malaysia, Dr. Tong. We have Dr. Su Wei Wang in Taiwan, as well as Ajahn Anitaya in Thailand, who's leading their respective hubs. And we've also set up the local champions or community advisory groups in these hubs. And currently, we are at a step where we are looking at this online forum and also workshop activities to do trainings for our hubs and community advisory groups and our investigators. And at the same time, we are embarking on some formative research involving surveys and qualitative studies. And also we'll be making use of social media to disseminate some of our messages. Soon we'll be embarking on year 2, where we'll implement some of the interventions that we have so far planned, and we will be measuring the impact of our interventions throughout this time, and also we'll be engaging with the policymakers in all these various countries so we can have buy-in from the government and policymakers as well. And last year, in 2027, we will be holding another conference, either in person or online, to disseminate our learnings and also hopefully scale up the activities that we have. So the 3 goals we want to strive towards for this project is that we want the community support for a science-driven kind of clinical trials and dissemination of our scientific message instead of having a narrative-driven medical evidence. I always joke about how my mom and my aunts and my uncles always send messages based on stories and very attractive products that's sent over WhatsApp and Facebook. We want to change that narrative to more of something that is driven by science. So the literacy for science and clinical trials, that we can work together to improve for the community. And secondly, we can translate their understanding for science into a resounding voice, so that science is not just driven by academics, but also the community. And also through the projects that we have, we want to build the best practices and models that's ready for wider adoption. And for that, we really need political drive behind us as well, and also for other investigators and of course the community who's joined us today to do this together with us. So thank you very much, and I'll hand over back to the host.
Thank you, Dr. Mo Yin, for your insightful opening and for sharing an overview of the Advanced ID and the Community Engagement Project. Next, I'd like to invite Assistant Professor Shou Yiyun to give us an overview of the forum. Dr. Shou Yiyun is an assistant professor at the South Wei Hock School of Public Health and a lead scientist at the Institute for the Public Understanding of Risk, National University of Singapore. Over to you, Yiyun.
Thank you very much, Bei Bei, and good morning, everyone. and welcome to Reach Asia Forum. Next slide. The goals of this forum, and the first one is to provide a platform for sharing community engagement efforts in Asia. We also hope to stimulate ideas and explorations of how community engagement strategies can be strengthened and adapt to different cultural contexts. Next slide. So we are delighted to have attendees and joining from about 19 different countries and regions, and we will expect about 290 attendees for the two-day event who will join at different time points. Our public attendees are coming from about 20 different countries and regions. Thank you very much for being here. Next slide. So here is our plan for the next 2 days. So today is day 1. In the morning, we will explore community engagement in the Asian region and share insights, experiences, and strategies from speakers from Malaysia, Vietnam, and Singapore. Attendees by invitation will also rejoin the event in the afternoon to engage in group discussion on topics including strengthening community engagement, building and sustaining community advisory growth. And tomorrow, day 2, we will dig further and explore more strategies in community engagement, including co-design strategies, risk communication, and more. And the public webinar will take place in the afternoon of the Singaporean time. The invited attendees will also join further group discussion tomorrow in both morning and afternoon to further design activities in our regional hubs. I hope you will enjoy the 2-day event, and also a special thank you to our event team for their hard work in preparing for this event. So we'll start with the first expert talk session. Over to you, baby. You're muted, baby.
Thank you, Yiyun, and we will now begin our first expert talk. Before we begin, just a quick note. There will be a short Q&A after each talk. Please submit your questions through the Q&A tab, and Yiyun will select questions from there. Now it's my pleasure to introduce Dr. Akmal Yousaf. Dr. Akmal Yousaf graduated from Royal College of Surgeons in Ireland in 1992. He practiced medicine in the public and private hospitals for over 10 years, and later worked with the American International Assurance Malaysia as medical manager. Later in 2002, he leads the medical department in AstraZeneca, Malaysia, Singapore, and Brunei for 13 years, where he gained extensive experience in the pharmaceutical industry, clinical research management, regulatory, medical, and government affairs. He has been the CEO of Clinical Research Malaysia since 2015. Dr. Akmal Yousaf is also a member of the National Committee for Clinical Research and the Board of Trustees National Institute of Biotechnology, Malaysia. Dr. Akmal Yousaf will speak on Clinical Research Malaysia's initiatives to drive patient awareness. Over to you, Dr. Akmal.
Thank you very much for the kind introduction. Thank you very much for the organization for inviting me to speak this morning. I like to put in my slides. Can you see my slides now?
Yes, good.
Can you hear me well? Good. Thank you very much for the kind introduction. Let me start by introducing Clinical Research Malaysia. It's a site management organization for the Ministry of Health that manages more than 30 centers in Malaysia. But our responsibility is also working with the private and also the academia in terms of helping them to get more clinical research. Focus is more on sponsored research. But I think Dr. Moin has already set the tone right in terms of how this can affect in terms of the way how we manage clinical research, especially recruiting patients. So a little bit about CRM, we have already been self-sustained since 2019. We have a very vast group of people reporting in the organization, around 280. Therefore, we have to have a very good system in terms of quality management. And with the effect that we manage funds and procurement, so that means we need to have a very good system in terms of the risk management for anti-bribery. CRM has been functioning since 2012. These slides are actually what I call designed and devised by my team, and I like to give my gratitude to them as well. Right, CRM goes in the principle of humanity, stability, and sustainability. On humanity itself, we bring clinical research that matters to the public in terms of addressing their issues with regards to medicine, especially the unmet needs. So does the doctors as well. By saying that, we believe that we need to be clear about building the public trust and being transparent in terms of what we do in clinical research. We need to improve, especially when we're talking about humanity, the trial accessibility and diversity. We must make sure that all patients has the ability to understand about clinical research, and as a result of that, would be interest in terms of enroll in the clinical research. So therefore, we need to have a good and strong patient-centered approach. And because of this, it also lies down to a better communication in terms of informed decision making for one particular patient, their family, relatives, but most of all, doctors that actually communicate to the patient itself. So in the study that we look at in group of people in the Sarawak, it's a dipstick study to understand what are the knowledge of awareness of clinical research. We understand that 40% of Malaysians have heard of clinical research. The awareness is still not strong. And if you look at the information sources that we have, 10% are from the doctors, 9% they know from the social media, and 9% from family or friends. And in terms of knowledge of clinical research is pretty much poor with only 30%. The gaps that we see is that people fail to understand what's the purpose of the trials itself. And because of that, we believe that there is a lack in terms of participation of this clinical research. There is also understanding about how does the knowledge and the willingness to participate. It's looks like it is balanced, but having said that, the awareness all are based on what have been alluded earlier: ethnicity, religion, the level of education, and also the social category of the people. In overall, we see that the willingness to participate in clinical research still can be improved, around 40.5 out of 100. And looking at this, only 13% show high willingness. And from this, we see that the willingness to participate is highest in the medical device trials with all these IoT, things like that, but it's lowest in the new drug treatment. And we look at the whole scenario. There is no difference between the cancer and non-cancer. It's similar, but the cancer patients slightly more willing to try in terms of new options of treatment. So what are the public perceptions? They believe that there is a benefit of doing clinical research from these samples, and there is a perception that there might be a high risk in doing so. And a lot of concerns is about safety, treatment that might not work, and feeling that they are a test subject. So the confidence of this conduct of clinical trials is because of that, it's pretty much moderate. Less than half actually trust that there is a good safety, a good ethics, and of course, a good rights protection for that matter. There is a 10% that is relating to the religious barrier. Now, looking at this, what we can sum up in terms of the key barriers, I think there is a lot of still misconception and fear to be enrolling in clinical research, in particular when clinical research is not an easy subject to communicate. The subject itself is very dry. So there is a lack of knowledge on this. There is also a perception that there is a high risk in terms of involving in clinical research. There is a low confidence in terms of the processes. I boiled it down to a lot of lack of communication to understand that clinical research is well governed and well, managed in terms of the conduct in Malaysia. And then there is also interesting finding in terms of social demographic gaps. Women and unemployed are less willing to participate. I think this need to validate later in a bigger trial. So what's the situation now? The implication for us is that I think there is a significant and awareness and trust gaps between the people, clinical research. And I have to say that the gap is also in the profession itself. Because the thing about clinical research, we have not gone to a part where clinical research should be part and parcel of the clinical management of each individual patients. The options must be, is not really explained well in terms of maybe some healthcare professional, yes, but some maybe they need to be improved because the gap remains of not including it as a part of option for patients. There is also a need targeted communication. One of it is community education. This better communication must be improved with a lot of transparency activity, especially in terms of clinical research, the process, and of course, in need to have a new ways in terms of working to get to the specific communities in terms of outreaching them. So in CRM, we put in these 5 things from what we have learned. Some of the activities we have done this before, and we are trying to make sure that we improve it. We can boil this down to 6 major strategies. One is about giving a campaign about understanding of clinical research. We call it the I'm Aware campaign. Second, working with the patient support group, specifically maybe working in support group in diseases for that matter. Thirdly is social media outreach, which is inclusive of the media print, media broadcasting, and also media, social media like LinkedIn and so on. Fourth is about publication, which is related to the social media outreach, but it is more towards what you call that scientific publication as well. And then we need to have clear, meeting of the minds with those who has entered the clinical research. What do they learn from there, and forum for that matter. And from there, we can understand how to design clinical research better, but at the same time as well, provide the understanding to those who are on the fence to understand that whether clinical research is the way for them to move forward. We have every year conduct a clinical trial. We actually observe this In a bigger picture, what we call as Clinical Research Malaysia Trial Connect, and within that particular program, we celebrate Clinical Research Trial Days. These include forums, more patient education. So we champion these activities, community awareness, to have people to understand the accessibility of clinical trials through campaigns, patient collaboration, and education program. We launched I Am Aware program in 2017 to strengthen the understanding of clinical research. If you see those photos, these are our team together with some patient groups and the hospital staff. It is driven through the annual roadshow in public and private hospital and also academia. And these are actually quite extensive in terms of the sites actually that conduct clinical research that participate in this program. We create an open dialogue, tackle misconception face-to-face with people that walk around in the hospitals and the potential relatives of patients for that matter. And we see there is a small number of people register yearly to participate in information gathering and trial participation. So this is a piecemeal that thought is good to have direct communication to people. Secondly, we work with patient support group, and these are the number of patient or the names of patient support group. We are working very closely with the National Cancer Society Malaysia to understand in terms of what are the needs of the patients. The Ping Unity is another cancer group. DEBRA is a group that actually looking at rare disease, and often we understand that these are the type of diseases where there is not much of support and so on. So our main objective with this engagement is to raise awareness among those in the communities and their caregivers. And with that, right access in terms of reliable information of clinical trials. And from working with this patient group, we have a lot of speaking engagement, like say dual language seminar of clinical trials. And we have a rare diseases society speaking in the, what do you call that, disease modifying drugs study sponsors for that matter. And then we got a speaking slot in the symposium that is organized by their society. And for another group, which is Ping Unity, they themselves actually carry out the process of I'm Aware roadshow. That is a very interesting, reaction. These are some of the activities that you see on the right corner. One is what a particular thing is about. We work with the ex-patients, oncologists, together with experts to give online, what do you call that, forum and so on. And our team is also speaking in several invitations. The other thing that we do, which is slightly different, I think, is to engage our patient group with the regulators. So they will know that it is one, this clinical research is well governed, and the regulators has their sets of rules and that needs to be done, especially the regulatory framework and the what they call that regulation that is in Malaysia. So patient will know what's their rights, what does the clinical research, how does it manage, and the regulators will have hand-to-hand to understand what are the needs of the patient's group as well. So this is very important because sometimes you never know, you put in a regulation that doesn't really make sense to the patient community. So the other one is about creating a portal about how patients could actually go to this portal and understand what is going on in terms of research in the country. CRM create this portal so that patient can look at it in the online platform, and a list of the number of studies is seen, and how can they participate with direct communication with the study team in the particular hospitals. So with this, they know where to go, what diseases are there in clinical research, which hospital is nearer to them, and there is people that is manning behind it to help them to negate whether they are can gain the inclusion into the clinical research or not. The other thing that we do is also outreach in terms of the clinical research itself. We actually put in time in LinkedIn and all these social media, what do you call that, apps, to make sure that our message is clear, like some diseases that we need patients to come in, without mentioning the study, without mentioning the trial itself, but gaining interest for patient to actually contact us, and we can address to the right parties. We do this because our social media has now have more than 100 million traction in terms of impression with all those apps, LinkedIn and so on. So we believe this is not only good for what they call that, reaching out to people, but it also gives the education to others that clinical research is very much alive in Malaysia. Collateral media is about getting us to be, coming out with our own thoughts about clinical research, to address in terms of these through the social media platform, interviews, publication, and of course, some of the things that we do is published in the newspaper to make sure that the general public understand that clinical research with these articles and opinion pieces would help in terms of a better, what they call it, option, or at least some we can highlight in terms of the trial participation in the country. The second last one is the patient engagement forum. This usually done one independently, and secondly, the photo is actually talking about one activity in the CRM Trial Connect, where we invite patient groups, patient who has already included in clinical research, patient who has already what they call that, completed the enrollment. What are the things that they can talk about not only improving public awareness, but also understanding, what can be done better in terms of the design of the clinical research itself. The duration of the treatment, the number of visits, those kind of things are discussed during this forum. So we had already people who are in the lung cancer, breast, thalassemia, hemophilia, and also idiopathic pulmonary fibrosis. So the other thing is about celebration of Clinical Trial Day, and we make this to motivate not only the patient but also the investigator, study coordinator, support groups, so that regulatory bodies as well and ethics committee come together and view this as not as a piecemeal work. We can't be working as a silo, so we need to make sure that everybody see the same page and the reason why we do the clinical research itself, and to make it easy for the patients. For us in Clinical Research Malaysia, we have around 215 study coordinators. I always tell them that these patients that enroll in clinical research, they do it out of science, they do it out of their passion, and of course their maybe journey to the treatment. And apart from completing their job, the study coordinators is encouraged to actually have that open conversation, listen to them. Sometimes these patients do not have anybody else to speak to, and the study coordinators is probably one that walking the aisle of clinical research with them, who can listen and motivate them to actually continue in terms of going into the clinical research without, of course, coaching them. So moving forward, I think there is a need to drive patient involvement in clinical research. For instance, Malaysia participate around 170 sponsored research per year, and we only recruit around 3,000 patients, whereas Australia, a country that has a similar population with us, is recruiting nearly 90,000 patients. I know it's not an apple-to-apple comparison, but I think this is the thing that we need to drive, is this patient awareness that need to be changed, and that's why we need to strengthen the awareness of the people and educate them that these nationwide efforts can help in terms of delivery, the knowledge of the purpose why we do the clinical research for science, for the health, and for the unmet needs and so on. And of course, it's being very well regulated, like the regulatory looking at the safety and also how these can contribute to the progress of science and medical for that matter. And of course, you need to have a good expansion in terms of partnership with new communities, patient groups, local organization. This is only a small part of what we do in clinical research. Malaysia, of course, we do a lot of the research management as a site management organization, finance, legal, reducing the time to conduct clinical research. But I think when we do this, we also need to spend times on patient, and that's why we are doing this. And I thank you very much for your attention. I thank my team for preparing the slides. And I hope it makes sense to start the ball rolling this morning. Thank you so much.
Thank you so much, Dr. Akmal Yusuf, for the excellent presentation. We are now open the floor for Q&A. Over to you, Yiyun.
And thank you very much for the insightful talk and to share all the wonderful initiatives CRM has been carrying out in Malaysia. So while we are waiting for the questions coming in from the audience, I possibly will start with the first question. And I think like Dr. Akmal Yusuf, you mentioned that the awareness and the general knowledge of the Malaysian population and the public on clinical trials has been lower at the beginning. So the community education can be quite important. So what are the barriers you have been facing in terms of like increasing the knowledge and carrying out community education activities?
I think the perception of people still thinking that clinical research is like a test. That is a big barrier for us. Communication, I think that the biggest one. And the second one is the range of us can actually expand. That's why we put in our clinical trials information in the website. But having said that, the reach is a barrier. So I think those two things are very challenging. The communication is not coming from us alone. I think the communication must be better through the healthcare professional as well. Doctors, nurses, often when they are very intrigued with or very depth in their services, clinical research is often neglected. And of course, we work with only a certain group of hospitals in Malaysia. In total, we work with 260 centers, but when we take care of the Ministry of Ministry of Health, the public hospitals, there's only around 30, and there are many, opportunity to work on others like the health centers, especially when we are looking for more patients, for that matter. This is indifferent because this is related to the patient recruitment strategy. So did I answer your question? I stopped there.
Yes, I think this is a wonderful answer. So reach to the general population is not easy, especially you need to go through different channels, and you need a lot of cooperation of and healthcare professionals. They usually their primary person communicate health and medical information with the patients. And so we have a question from the audience. So when attendee ask, what type of information about the clinical trials that you often communicate with the public and on the different platforms?
My team has been very tactful, and we are very tactful with the requirement of ethics and so on. So the communication is very general. It's about are you having friends or relatives or yourself breast cancer? Let's have this conversation with us. There are clinical trials that we can discuss with. So those kind of things, as an example. Having said that, I think the beauty about this, when the patient group sees this, that excite them immediately, especially the rare diseases, they will come to us, and in certain situation, they request that please bring this type of clinical research to Malaysia. That is, to me, one huge challenge. I'm very happy with that challenge because there is a need for these, what you call that, types of studies people are requesting. On the flip of the coin, it's also not easy to get this study to come to Malaysia. We need to convince the principal, the sponsors, that there are, patients in Malaysia that, may be suitable for the clinical research. So, yeah, to answer your questions, information is pretty much basic. It's being taken up by patient group, and some patient group even ask difficult question: why does, no study coming from my disease and my association members? So this is something quite difficult to answer, but we never stop for the humanity.
And thank you very much for the answer. Definitely, clinical trials can be very complex, and you cannot go with a lot of details. But starting with the basic information is the first step for raising awareness. And I actually have another question. So, what are the roles of trial teams, investigators, researchers, and hospitals in the different kind of community engagement activities CRM has been carrying out?
I believe the successful of the investigator for the clinical research boils down to the study team. And we play our part in terms of the study team, like the study coordinators and so on. Not only to be able to understand 100% about the protocol and working with the team to make sure that the study is following the protocol in terms of methodology, but there is a certain part, which is the soft skill, which I explained to you. And in order to motivate people to come into the clinical research, we have all to work as a team. That includes the investigator, the study nurse, the study coordinators, the study team in the whole thing. I can see that if I do a cohort of groups about clinical research, those investigators that and the team that is actually outreaching to the patient does really well. And in terms of getting more people to trust in terms of clinical research, but versus those who are a bit passive on that basis. That includes the number of patients, that includes in terms of the trust of the patient as well. So I think Dr. Moin did explain to you about the hesitancy during the COVID time. And I think that is a testing period for us, because it also means that we have to be clear that we cannot coerce the patient during the pandemic to be recruited in the clinical research, balance that with the needs of the science for that matter.
Thank you very much. I think, yes, it's not only one single party's responsibility, it's multi-parties like responsibility in the whole process.
It's a multidiscipline team.
Yes, definitely. And then thank you, Dr. Kamal Yusuf, for your wonderful talk. And in the interest of time, we have to move on to the second speaker. And over to you, Bebe.
Thank you so much.
Thank you both. We are now move on to the next expert speaker. I'll share my screen.
I stop my sharing, sorry.
Okay, our second expert talk will be delivered by Associate Professor Christina Misa Wang. Dr. Christina Misa Wang is an Associate Behavioral Scientist and Associate Professor at the Saw Swee Hock School of Public Health, National University of Singapore. Her work centers on clinical trials and implementation science, with a particular emphasis on HIV prevention technologies such as oral PrEP, vagina rings, and non-acting injectables. Dr. Wang has played key roles in multi-country phase 3 trials, with her research and efforts contributing to informing clinical trial procedures, participant recruitment, adherence strategies, and fostering strong community and stakeholder engagement. Her research has informed HIV prevention policy and program development internationally, and she has also led initiatives in reproductive, maternal, and child health and nutrition across Africa and the Asian Pacific region. She will speak on creating community advisory groups. Over to you, Christina.
Thank you, Bebe. I'm just going to be sharing my slides right now. And excuse me for clearing my throat because I'm trying to get over a cold and I have a lot of throat irritation today. Okay. You can see my slides now.
Yes, all good.
Okay. All right. Well, welcome everyone. Today we're going to be discussing how to create effective community advisory groups. I may be calling community advisory groups CAG, and we're going to be talking about community advisory groups for clinical trials and research. This topic is increasingly important right now as we seek to make our studies more ethical, inclusive, and impactful. And the insights from community advisory groups can transform research by ensuring it truly serves the needs and priorities of the communities involved. Here's an overview of what I'll cover today. I'm going to start off with why does community engagement matter and walk you through with the basics of what CAGs are, how to set them up, potential challenges, and then I'm going to also share with you a real-world example. So here's a little background. Clinical trials and health research depend on effective recruitment of participants into the clinical trial and also their consent. However, what we're facing right now are some challenges, and these include cultural diversity, language differences, varying levels of health literacy among participants, and also mistrust in the community with clinical trials due to past controversies. And in the next slide, I'm going to show you one of these past controversies. To address these effective community engagement, community engagements is important. And also in Asia, community engagement in clinical trials has often been suboptimal, leading to low clinical trial participation and also low retention rates. And this not only threatens the scientific validity of trials, but it also increases costs in research and healthcare systems. Here in this next slide, I would like to share with you an example of a clinical trial that had to halt because there was insufficient community engagement. I'm going to be talking about the tenofovir HIV prevention trial, which was held in Cambodia in 2004. The primary reasons for the trial discontinuation centered significantly on ethical concerns. Firstly, there were serious doubts about whether participants were properly informed about the risks, benefits, and their rights within the trial, issues with the informed consent process, and also there was a lack of clear, culturally appropriate communication that led to mistrust among the volunteers and the advocates. Another critical issue for this trial was that there was insufficient engagement of community stakeholders. The local sex worker community, which made up a significant portion of the study population, and advocacy groups were neither adequately consulted nor were they involved in the trial's planning and oversight. As a result, concerns over post-trial access to care, monitoring for side effects, potential exploitation were all not addressed, leading to vocal protests and international criticism. Local and international NGOs also highlighted these gaps and called for the trial to be stopped until these concerns could be resolved. Through this experience, it underscores the absolute necessity of robust community and stakeholder engagement in clinical trials. When communities and key stakeholder groups are involved from the very beginning, they help ensure that trials are designed and conducted ethically and transparently. They can flag potential risk, guide culturally sensitive communication, and advocate for participant protections, such as access to care after the trial. Building such partnerships not only prevents misunderstandings and mistrust, but also increase the chances of successful recruitment, retention, and eventually the implementation of scientific findings to scaling up in the community. Okay, so I just want to share with you that the WHO also has guidelines in including community engagement as one of the key components to strengthen the clinical trial ecosystem. Community engagement is essential because it builds trust between researchers and participants, helping to overcome skepticism and potential resistance. By involving local stakeholders early and throughout the trial process, we ensure the research is relevant, culturally sensitive, and addresses community priorities and concerns. This collaboration helps identify potential challenges or misconceptions before they become barriers, leading to improved recruitment, retention, and adherence among trial participants. How then can we engage the community? There are different levels of patient and public involvement, ranging from informing people about what researchers do to collaboration and empowerment, as illustrated here in this slide. Researchers often claim that they are involving people by informing the public about the results of a study through a lay summary or a media output. It's a one-way communication based on professional expertise, whereas true involvement requires researchers to listen and act on the patient-public view in the design and conduct of their research. The empowerment end of the continuum means the research is user-led. Patients and the public are in charge of the research, and an effective patient and public engagement strategy for a research study or program might require activity at all levels of the continuum. The level of community involvement that a study chooses can also be different at different phases of the study. So for instance, a community advisory group could be involved in the study design phase of a clinical trial with lower levels of involvement and may play a consultative role when it comes to designing participant recruitment and retention strategies. The level of involvement will depend on the needs of the research team, the community, the funder, resources available, and also other needs. Today, I'd like to talk about a more formal group to engage the community. A community advisory group typically comprises people who represent or are affected by the research. They provide ongoing feedback, not just at the start of the research, but also throughout the research journey, and can also serve as a bridge between the researchers and the affected community. The aim is to ensure the research reflects community needs and values. The community advisory groups may also be known by other terms, such as community advisory boards or community advisory committees. Okay, so community advisory groups can also transform research by making it more relevant and trusted. They help also uncover community-specific issues early on, increasing recruitment and retention by promoting trust and also ensuring that the participants' rights and well-being are prioritized. So what are the key roles and functions of the community advisory group? There are many different functions, and not all studies will utilize all these different functions. And they can be involved in, and these CAGs can be involved in many different ways at different phases of the research process. So for example, CAGs can review study documents, such as informed consent forms for clarity and sensitivity, providing input on recruitment strategies, and also helping with the communication of trial results. They're also very useful for flagging emerging issues in the community, misinformation that they're hearing within the community, or rumors that could affect the trial. So what I'm trying to say is that there is no one size fits all in terms of the level of involvement. There is a continuum in terms of the level of involvement, and each trial is different, and each trial will decide on how they're going to involve the community. The other aspect that the research team has to also decide is where should the CAG start to get involved? Which phase of the study should the CAG start to get involved? Here, I'd like to share with you the different steps to initiating and conducting community engaged research. Like I was saying, there could be different phases of the research where the community can start to get involved. So I'm going to just show you here in this study what they did. So this study described the experience of the program in community engaged research, which was a core program of the Clinical and Translational Science Institute at Wake Forest University School of Medicine in North Carolina in the US. Community engaged research here was recognized as a strategy to address health disparities and promote health equity by ensuring that research is relevant and beneficial to communities that are often underserved. You see that for this study, they focus on involving community members and organizations as equal partners in all stages of the research process, starting from when they were identifying and engaging community members right through to the dissemination and translation of the research results together. However, what we are seeing a lot in the literature is that the community starts to get involved in the collaborative study implementation phase through to the joint analysis and interpretation, and also the dissemination and translations of the results. So these three last phases are where very frequently a lot of clinical trials involve the CAGs. Coming back to how to create CAGs, first of all, it's vital to define why you're forming a CAG. What is the CAG for, and what do you want to achieve? Also, we want to figure out their level of involvement. Will community members just simply advise, or do they have a more active partnership? Will the CAG be specific to this one study, or will the CAG also advise on a group of studies? The other thing we need to do is developing clear objectives to steer the group, and the use of the terms of reference document has sometimes been used to set the foundation for roles, responsibilities of each of the community advisory group members. How often do they meet, the scope, and also ensuring that everyone has clear expectations. So how do we identify who should be identified as community advisory group members? Let's start with a stakeholder map. And we want to identify all relevant stakeholders. Here I have described a few different groups here: patients, caregivers, advocates, health professionals, community leaders, NGOs, policymakers. And we must not forget that we should also include the marginalized, the minority and underserved populations, and others who may be affected. In other words, diversity in a group will ensure that various perspectives and potential barriers are represented and addressed. CAG members may also share the perspective of the organization they work with and/or their own perspectives based on their personal and family experiences with research, their health needs, and healthcare utilizations. Also, their perspectives are enriched with their involvement and interaction with the communities they work and live in. Let's talk about how do we recruit CAG members. There are different methods. There can be open calls. There could be an advertisement going out in the community to recruit CAG members. There can be nominations. There could be partnerships with community organizations where they can also nominate. It can be really broad, and it can also use multiple channels. But what's important is that the process is clear and the criteria also is clear, and that you want people with relevant experience and, very importantly, the willingness to serve and engage with other CAG members and on this study. And we want to also include others who are not there, not only those with formal education, but also we may also want to include others who are extremely interested to serve in this CAG. It will be great to aim for a group size of 8 to 15 so that the facilitation can be more effective and there is better dialogue. If you have a bigger group size, the tendency is that there will be some group members who may feel left out or may just be very quiet. Let's talk next about the group structure and governance. First of all, the leader or the co-chair of the CAG. You could choose to have a leader or leader that can serve for the entire duration of the CAG, or they may rotate. There may be limits in the duration of being a leader or co-chair, and as long as they are clear and that all the members know, that would be sufficient. The other thing that's important is also clear roles. Who are the members of the CAG? Who are the observers, if any? And who are the clinical trial or research staff liaisons there? Establishing regular meeting frequency is also very important. Some CAGs meet monthly, some meet quarterly, some may meet quarterly, but then they may meet monthly if there are more urgent or more pressing issues to meet and discuss. And also developing a code of conduct, a confidentiality agreement can help with protecting sensitive information and also support a safe environment for honest discussion. One of the things that we don't always assume is that everyone is familiar with research jargon or concepts. So we're going to have to start with plain language orientation and provide ongoing training that include things like what are clinical trials? What are the different clinical trial phases? What are the study designs like? So these kinds of trainings are extremely important to bring everyone up to speed. Also, regular updates on the study progress and keeping members engaged and informed is important to ensure that their input remains relevant throughout the trial. Okay, setting operating procedures are also important. We need to establish meeting schedules, the format, whether it's going to be in person or virtual or hybrid. And then there are some times where there are co-creation of agendas with CAG member input, especially if they would like to hear more about certain parts of the clinical trial or the research, or if there's also training that they want. Meetings should also be scheduled at convenient times and made accessible to all. And the decision-making should be transparent and records should be shared to ensure accountability and track progress. It's very important to integrate the input that the community advisory group provides in these meetings into the research. And the researchers should also develop structured feedback channels so that they can input they can add in these input from the CAG into their research. These feedback channels could include written reports, regular presentations, and researchers need to also formally address CAG recommendations. What are the actions taken to their recommendations? And also, if you're not adopting these actions, why is it that you're not adopting them? And also acknowledging member contributions, if they do consent, demonstrates respect and transparency. Okay, so going on to monitoring, evaluation, and sustainability of the CAG. One of the ways to do that would be to collect regular feedback from CAG members and also the research staff so as to improve the CAG effectiveness. You could also use surveys, interviews, and focus groups for the evaluation. And you can, based on the feedback that they provide, then adapt the CAG meetings based on that. You also want to measure both process, which is their engagement and also their satisfaction level, and also the outcomes, how the CAG made an impact on the research. And then finally, you want to plan for longer term engagement or renewal or transition to new projects when the study has finished. Navigating challenges. There are a few challenges or many challenges sometimes, including the recruitment and retaining of diverse and representative members. There may also be tension between scientific, ethical, and community perspectives. And it's also important to address these openly and have mechanisms for conflict resolution and confidentiality. Before I end, I would like to illustrate how community engagement was conducted through the use of a community advisory board for the FEMPREP clinical trial that I was involved in. So just to give you a background, the FEMPREP clinical trial was a major multi-country phase 3 study designed to evaluate the effectiveness and safety of a daily oral pill that you see, the blue pill that you see in this slide, and in preventing HIV among women at elevated risk. So the trial was conducted in 4 sites in South Africa, Kenya, and Tanzania. And while the biomedical outcomes were crucial, a unique strength of this FEMPREP clinical trial was its focus on understanding how social and behavioral factors affected product use and study participation. So in trials like this, community engagement is essential. Working closely with local communities help ensure that the research addresses real concerns, is culturally appropriate, and earns the trust that is very important for successful recruitment and retention of participants, and also to identify and address ethical or practical challenges before they can disrupt the study. Okay, so let's look at the formation and the composition of the community advisory board for FEMPREP. Each of the clinical trial sites had a CAB established. And this was formed prior to the launch of the clinical trial. The establishment process was collaborative. The research team consulted with local non-governmental organizations, civil society groups, and respected community leaders to identify potential community advisory board members. This ensured that the community advisory board reflected the diversity of the communities affected by the trial. Membership included representatives from women's groups, local healthcare providers, religious and community leaders, youth advocates, people living with HIV, and those representing key at-risk groups for HIV. In some cases, even local government officials were included to strengthen ties with public services. So the CAB for FEMPREP played several pivotal roles throughout the trial. They were involved in reviewing research protocols, participant materials, ensuring that the language as well as the concepts were accessible and respectful to the community. The CABs also gave invaluable advice on community education campaigns. They also helped to tailor messages and materials so that they resonated locally and addressed specific concerns. And when potential barriers to trial participation were identified, such as stigma and misinformation or practical challenges, the CAB members brought these to the research team's attention and then often helped co-create solutions. So the CAB's role as intermediaries was definitely essential for maintaining open communication between the research staff and the broader community. And the input from CABs directly influenced important trial procedures, especially around recruitment and retention strategies, making them more effective and culturally sensitive. The CABs also played a key part in addressing rumors or ethical concerns, helping to build trust and understanding even after the trial. And then even after the trial, the CABs continued to advise the team on how to communicate results back to the participants and the broader community and laid the groundwork for future partnerships in clinical and public health research. So before I end, I would like to share some best practices. First of all, early, honest, and ongoing engagement is best. Keeping communications clear, explaining your decisions or non-decisions, and recognizing CAG achievements is important as these practices build trust and set the stage for collaborative, impactful research. Okay, so to conclude, CAGs are more than an ethics requirement. They are partners who enrich and strengthen research. The time invested in building these partnerships pay off in study quality, in community trust, and research impact. I have some resources for you for further guidance. And I just want to thank you all for being here today and being part of the online forum. Thank you very much.
Thank you, Christina, for the valuable insights on creating community advisory groups. We are now moving into a short Q&A. Over to you, Yiyun.
Thank you very much for Professor Wang for your wonderful talk and guiding us through the details on how to build the CAG and what are the tips on the building CAG. So we have the question from the audience. So the audience, the attendee is from the rare disease, Malaysia. And the question is, you mentioned introduction and ongoing training for CAG members. So in a setting like Malaysia, what would this actually look like in practice? Who usually leads and fund this kind of capacity building? And do you have any examples you may be aware of? And the second part of the question is how to work on settings that with a small number of patients.
Thank you, Ian. Those are excellent questions. The first question was, sorry, I'm blanking out right now. Okay, so let me address the second one first because it's still on my mind. How to work with small communities. I haven't worked with small communities before in clinical trials, but I have worked with small communities, actually in Malaysia, on involving the community in defining what to intervene in their village. So this was a village in Sarawak, in the state of Sarawak, which is in a rural area among the Iban community, and we work with them to come up with problems that they are seeing health problems that they are seeing in their communities. A very small rural village. I can't remember the top of my head. Yeah, I think it must have been over 100 people maybe close to 100 people in the community, but not everyone was living there because some of them were working in the town. But what happened was we involved the village. There is a village leadership team, and we involve them in setting priorities for what are the health problems they see in their community, and then also deciding which health problems do they want to prioritize, and also coming up with an intervention. But first of all, we also did what is the health problem and how big is this health problem? So the community actually designed their own survey. They went from door to door and had this household survey. And then at the end, we taught them how to actually analyze the data and present the data back too. So that way they were involved from the very start in prioritizing the health problem, in figuring out how big is this health problem, doing the research with training from us, and then finally presenting the results of the formative research back to the community. And then with community consultation, they designed an intervention, which was an environmental health intervention in their community. So even with a small community, you can actually work with the community leadership and other concerned individuals in designing and also guiding them further on with an intervention. Okay, the second question was, sorry, Ian, please remind me.
So the other question, I think it's not only in Malaysia, possibly like researchers from other countries will also have similar question. Usually, who leads and funds this kind of capacity building?
Okay, so who leads this capacity building? So it also depends a lot on the topic. So in the community advisory group, we will always ask them, okay, so what kinds of training do you need? If there are a lot of lay people, they may ask for training on what are clinical trials, like the study design of these clinical trials and the different phases of the clinical trial. What does this mean? All the different scientific jargon, and also like what is a case control study, all these put into layman's terms. So together with the community advisory group or community advisory board, we will decide on what kinds of training do they need. And sometimes maybe not in one session, because they can tell you at one session, but then later on down the line, they realize, oh, actually we do need training on this certain thing because we don't understand what these trial results mean. How do we then communicate? How about we need some media or communication, like training? How do we talk to the people about these trial results? So we may come in to bring in an expert on how do we communicate trial results back to the community. So it's actually a consultative process, an ongoing process that may keep changing too, because new topics may come up.
Yeah, so Christina actually usually it's the research team and possibly with experts in this area, they need to lead this effort. And usually who actually provide funding for this kind of activities?
Yeah, funding is always very tricky, right? Because, funding is not infinite. Funding is always provided in the studies I work with, is provided by the research funding or the clinical trial funding. And we try to find people within the community who can provide these trainings, or someone from the research team or someone in the community that can provide this training so that they can also be more culturally sensitive.
Thank you so much. Definitely, we need a lot of work on different aspects on the CAG, but we also need to start at the first place. And so in the interest of time, we are going to move on to our last expert talk. And over to you, Beibei.
Thank you, Yiyun, and thank you, Christina. Now it's my pleasure to introduce Dr. Kwang Thi Hai-on. Dr. Kwang Thi Hai-on is a medical doctor trained at Hanoi Medical School and holds a master's in sexual and reproductive health research from the London School of Hygiene and Tropical Medicine. She co-founded the Institute for Social Development Studies in 2002, and later the Center for Support Community Development Initiatives in 2010, where she now serves as the executive director. Dr. On has worked across the health and development sectors and has served in several international advisory roles, including on the WHO strategic and technical advisory groups on HIV, viral hepatitis, and sexually transmitted infections, the UHC 2030 Steering Committee, and the Scientific Advisory Board of ANRS Emerging Infectious Disease. She's also a co-principal investigator on research projects related to drug addiction, HIV, TB, dengue fever, and mental health. Dr. On will speak on building trust and participation among marginalized communities. Over to you, Dr. Wang.
Thank you very much for the introduction, and it's really nice to present after other speaker, because I think it's I will bring into a little bit different approach. I mean, in the same line of engagement with the community and with the people affected by research, but in a different format. So I will start first with some concept, some understanding that we have learned through the work with the community and doing research. So we started the I just want to share with you one of the projects that we've been research project that we've been working for the last 13 years. We started a project, a research project with people who inject drugs in a city in Vietnam. With the key question is that, is it possible to end HIV transmission in the low resource setting, middle income country, lower middle income country like Vietnam? When we submit the proposal, the donor, the funder, didn't believe that we was able to recruit enough active injecting drug user, and that they also not convinced that we be able to follow them up for a long time to see, to be able to document, to observe the incident of HIV. But because our proposal are quite convincing, so they agreed to give us a small grant to do a pilot. And to everybody's surprise and impression, we recruit in a very, very short time in a sample size, and we was able to follow up to 86% of the active injecting drug user within 6 months. And we know exactly what happened to the people who didn't show up to the follow-up. So that was very convincing. And because of that, we was able to get the funding to do the research on ending HIV transmission among people who inject drug. We also get the funding to do other research with the same population. It evolved over the time about the TB, about the methamphetamine, about COVID, about hepatitis C, on issue of gender, on mental health, etc. And so it started with an idea, with a proposal for doing research in 5 years, and now 13 years later, we are still working with them. The idea of doing a first research on HIV, and now it evolved into many, many other topics. And we are able to do so because we work with the community. And when I was asked to speak about trust and participation, I could see a very clear association, relationship between trust and participation. In order to get people participate, they need to trust you. And if they participate and they have a positive experience with their participation, it will increase the trust. And if they trust you, they can be honest with you, they can share with you their information, they can engage with you, give you feedback, etc. So that would improve the quality of the research. And if the research is of good quality, it can inspire them, it can empower them, and they can trust you more, and you can do more with them. So I think I see the three elements of trust, participation, and quality is like reinforcing each other. So let's talk a little bit about trust. I think you other speakers already mentioned that nowadays, and particularly this day, there are such a big problem with mistrust, right? There's so much scam, there's exploitation of data, there's misinformation, etc. So it makes trust even more important. But so what is trust? Trust is that the belief that somebody is reliable, honest, and will act on your best interest, right? They don't abuse you, they don't deceive you, they don't harm you. In fact, you trust somebody when you can be sure that the person take care of you or work on your best interest. So here are some key elements of trust, and I think it's really important for us to keep that in mind. First of all, it's about reliability. You say something, people can trust it. People can. It is reliable. You do what you say. You are being honest about a good thing, also the bad thing. So if there's any negativity about what you or any concern you share with people, you don't pretend there's no problem. The integrity that you have a value and you uphold the value, you are competent, you are able to solve the problem, or you are able to act on the issue if there's a challenge. You should be able to do so, and you care for them. So one of the things, like when we work with people who use drug, and drug use in many of our country, including my country, is illegal, and we are working with active drug user. So active drug user to verify that people are actively using drug, we need to do the drug test. So how can people trust us to give us to let us do the drug test on them when drug use is illegal? There was an incident when the police show up in our research site, and people are worrying. So we should be able to handle that. We should be able to prove to the people that we protect them, that we are doing our best to make sure to keep their confidentiality, but also to interact with the authority to protect their safety. So trust is very important factor for committed participation. If you do clinical research, if you do a longitudinal study, if you do a cohort study, or any study, you want people to be committed. You don't want them just to show up for whatever benefit you offer for participation, for show up, but we wanted a committed participation, for them to be honest with you, to share with you the information, to tell you what is going well, what is not going well. So trust is very important factor. And trust is even more important for marginalized population, because marginalized population as people who use drug, or people living with HIV, or some of the ethnic group, or some of the religious group, or some of the women group, or adolescent group, they are more vulnerable. So they are more cautious. The trust is more difficult to build trust with them. Although once the trust is being built, it can be very, very strong. So now let's talk a little bit about marginalization. I guess many of us have experienced marginalization. If you come to a meeting and people speak the language that you don't speak, you don't understand, and there's no translation, I guess many of us has been in that situation. They speak a tribal language or they speak a foreign language. If I show up in a meeting where people speak Dutch, for example, I would feel totally marginalized. So when I talk about marginalized, that it is being excluded. People don't or being disadvantaged. People are more powerful than you, and you are just like a second class, the third class. You are not considered, like I mentioned, you show up in a meeting and people don't care that you don't speak the language. They don't make any effort to translate for you. You are left out, or you are even pushed out because they don't accommodate you, or they purposely want to push you out. So marginalization can vary according to context, situation, and issue. So when we do a research, I think it's really important for us to see who are marginalized, who may be marginalized in this research. Because in any society, there are marginalized population, like I think in many of our society, people who use drug is a marginalized population. But in each population, there are marginalized group of people. Like among the community, among the population of people who use drug, people who have disability, for example, can be marginalized. If we request that people have to come on their own to our research site, the people who have mobility, who are on wheelchair, who cannot walk, can be marginalized. And in certain contexts, some people may feel marginalized. Like I mentioned, if you come to a room full of men who smoke, and you are a young woman who are shy, you may feel marginalized. So just to keep that in mind, when we do research, when we conduct activity, that we are mindful of not being marginalized people. So there are a lot of marginalized situation and people due to different factors, like a social factor, including stigma, like in many society, is LGBTIQ people are stigmatized and marginalized, sex worker, drug user. There are some norms that constrain the people, like in some society, married women should not travel without a male companion, for example, a male relative companion. So that's this norm that constrain. There are legal aspects that marginalize people. There's a culture, there's language, the religion, political, economic, communication, language, accessibility, mobility, administrative. Like in many of our country, there are illegal migrant, undocumented migrant. So if you do a population survey, are you going to include them? If you don't, are we really reflect the population? Does the result reflect the population that the result is supposed to apply to? So I often ask a question when people say, "Oh, the universal health coverage in this province or this country is 90% or 95%." My question would be, what is the denominator? 95% of what? Are you accounted for the undocumented people? Are you accounted for the people who are not registered with the authority, etc.? So that is administrative aspect of it. And there's a big question here I would like to raise with you, because many of you are doing clinical research, and particularly clinical trial. There's a big issue now, because there are some group are considered as inconvenient or too complicated to include, like pregnant women or children because of the consent issue, pregnant women because of the concern for the safety, people with disability because many of them are having difficulty to communicate or to talk or to come to participate, and the elderly people because of their some have a challenge in communication and mobility. So very often, and I think that is a big criticism at the moment, that the researcher don't make effort to include these people in the research, in particularly in clinical trial, because of the challenge. There we have to admit that there's a challenge to include them. But so some people choose a more safer option is to, okay, so our study is not going to include pregnant women, etc. But then these groups are in the disadvantage, right? Because they would say, oh, this drug is not recommended for pregnant women or like the breastfeeding women because there's no data. So so you can see that there's this double sword. On one side, we say we protect pregnant women, but on the other hand, it's actually we leave them unprotected. So in terms of participation, I just in the broader sense, participation, when you say we have a good participation, first we need to have a representation of different segments of the study population, including the marginalized people in the sample, right? So when you do a sample of women, do you have a representation of all different group of women? How about women with disability? How about pregnant women? How about the elderly women who don't speak the common language or who cannot use their own transportation to come to the research site? So that we want to ensure the good representation. And then we would like to have to achieve the committed participation. We want to have they give us accurate data. They don't tell us the information which is not true. They adhere to protocol. If you give them drug, if in the protocol that they need to take drug 20 times a day, they would take drug 20 times a day, and not skipping it and then tell you later or throw away the drug and tell them that, oh, I took all the drug. So so that adhere to protocol and responsive, and we would like to have the responsive participation, that they give feedback. So if you give them the drug 20 times a day, they can tell them, they can tell you like, no, it's not possible. I'm not going to do it 20 times a day. Can you do something else? Or is there any way that I can take drug 20 times a day without forgetting it? So that is responsive participation, and we want to get there. We want to get not only committed participation, but we want to get to the responsive participation, right? I am in the steering committee of a very, very big trial, and to learn more about the community participation in that trial, I talked to some of the principal investigators. And one of the questions I often ask them is that, do you get any feedback from the subject, from the participants? And some of them say, no, they are very grateful. They are very thankful to us. There's no problem. I haven't heard any complaint. Feedback is not only complaint, right? But it's you in particularly you are interested in to hear from them if there's any issue. So so I don't particularly impressed by that kind of response. Of course, it may well that for that particular group of participants, there's no problem at all. But to hear no feedback is it's a bit make me feel uneasy. But and I just want to say that participation is both right and commitment. It's a right for different group in the population to participate, so that the research result would reflect on their experience as well. But also participation is a commitment, like I mentioned before. And as a researcher, our responsibility is to fulfill people's rights and to facilitate the commitment. If we want people to commit to the research, to be responsive to the research, we need to facilitate. It's a work. Like a different model that we heard before, the patient group, the community advisory group. We need to, if you are not able to hear from every single participant, you should have a mechanism to be able to get feedback from every one of them. So only that we can facilitate the commitment. So to build trust, so we for us, we all know that I think everybody knows the story of Snow White, right? And with the poisoned apple, and it is well told. And so if somebody come to you and give you a drug and say take it, you would be hesitant unless you are very well informed about it, and somebody who you trust can give you some assurance. So you don't. We are in many situations. We are the researcher as a stranger coming from a different planet, and then give the patient, give the people this apple and say eat it. You can feel, you can imagine the feeling. So it is what we found have worked very well for us is that we have we create this triangle of researcher, community organization, and community population. So community organization is an organization of that particular community. Like when we work with the people who inject drug, we do research with people who inject drug. We start first with the community organization of people who inject drug in that particular city. And that help because the community know them and they are there. I come from different city or even different country, but the community organization is there, so they can take home take hold of this group of these people. So it's also an element of buying trust. So it's reliable in a way that they are there. They cannot run away. A researcher coming from another city, coming from other country may disappear, but the people are there. So I think that to work with the community organization is a great way to one of the first steps to build the foundation for trust with community. So for the research I shared with you that have lasted 13 years, it took us 2 years before we could start that pilot. We spent a lot of time to discuss, to meet, to discuss. It's not only to build the research proposal together, but it's through the interaction, a lot of interaction. We show mutual respect and we show mutual appreciation. We have mutual understanding. It's as between people to people. So human to human. With the researcher team coming from Vietnam, France, the US. Later on, we have people from the UK as well to join, learn to appreciate the experience of community. We all know that the community has the experience we don't have. They have the know-how that we don't have. They have the connection with the community that we don't have. So if we don't consider the community people just like the people who help us to recruit, for example, I think that that's not enough, but they have a much more than that to offer. So and they learn from us that we are not perfect, we don't know everything, and we are ready to learn. So it took us, we can see at the beginning, it was 13 years ago, we sit on the floor with the community group to discuss about different issues and to build the research project together. So together with them, we learn a lot. We learn about different population segments. We learn about people who inject drug. There's a different group of different type of people who inject drug, not only in terms of age, in terms of gender, but also in terms of their practice, their location, etc. We learn also what activity can be done, what cannot, and when. Like, for example, our police usually have a campaign to crack down on drug users just before the new year. So that is not a good time for recruitment, for example. They also advise us on which question to ask. So we discuss the questionnaire, so which question to ask, how to ask the question, and what make people come. So participation is first people need to come. So what will make people to come? What make people to stay? What important to them? So through a lot of discussion, but also like every day working together, we improve recruitment, we improve retention. Like I mentioned to you, we've been working with them for 13 years. We have people who use drug have been in our program ever since. We improve the quality of data. We can validate the results. So when we have some finding, we discuss with them, like, okay, so this is the finding. Why is this? What do you think of it? So like one time we got the finding that there are very high percentage of people reported to taking street methadone. So we discussed with them and to understand why is that. Apparently, we learned that it's at the beginning of the research. We learned that, in fact, it's not street methadone. It's other form of methadone that people didn't take from the clinic. So by that, we come up with also a lot of new research idea. Because in working with people who inject drug, first with HIV, but then we found that, and people keep, because we follow up on the cohort, and then we see that people die of TB, people die of hepatitis C, so we start to work on this issue. So our research sites run by community organization. So we recruit, our recruitment site is at their office, at the community organization office. So for people so when people come, they are not afraid, because the community are the people they know. They are not, many of them have experience of using drug as well as their friends. They've been to prison together. They've been to drug center together. So they can trust, they can be open to. So that is where we have our site, and they start many positions. So at the beginning, they was like just like supporting, look after the motorbike, or go and pick people up, check their coupon. But later on, they do many. Their role increase, and they even do the interview, because we see that people trust them more. So when they do the interview, we will get more accurate information, and particularly the sensitive topics such as drug use or sexual behavior. So we throughout the year, we increase our bond, we strengthen our bond, but we share value. It's a people center. So for the community organization, the community population is their people. So they take pride of taking care of them, of doing more for them. And so we do beyond research protocol, like overdose reversal. So when there's a drug user overdose, the team went to save the person. During COVID, they if the people need to be hospitalized, they went to methadone clinic to pick up methadone to bring them to the hospital. They take care of the people when nobody is taking care of them. So it builds trust with the community, that people know that we care. The community organization know that we care for their people, and they are able to care for their people, so that that become a very strong and special bond between all of us. So when trust leads to committed participation, then participation enhance trust, we can do more. We can do a lot more than the initial research idea. We become one team. You can see how big our team now. We started first with 4 co-PI. I am one of the 4. And then we grow the research. We have lab team, we have a clinical team, we have a epidemiological team, but we have a big community team, and everybody sitting together. So it's not only to tell them what to do, but to really discuss the research question, to discuss the operation, to validate the result. We have during the recruitment time, we have meeting every week with everyone. Then it had to strengthen the capacity of all of us, and it had to grow our team. We expand our scope, and we strengthen the mutual trust between everyone. So there's a lot of capacity building to be done, particularly, for all of us as well, but also for community organization. And capacity building here is not only about knowledge, but also about their organizational capacity. I heard the question before about who fund this. The research need to fund this. So it have to be a part of the research fund. They need to have their own space, so we make sure that they have their office. They need to earn their living. They need to live. So we make sure that they have some income to live, etc. So that is also capacity building, and we have them to strengthen their management capacity. So they are doing a lot of activity in the research, in particularly follow up with the participant, taking care of them. They are super busy, and it needs to manage very well, also including some data collection, etc. And because of them, we are able to get feedback from community. So one time we was doing, we tried a regimen, a preventive TB regimen, and later we never heard about any. It is not a clinical trial. It's an implementation research. We want to know how it should be delivered. And we never read anywhere about the severe side effect that people who use drugs, and particularly opioid drug, experience. So it never in the literature. But because of our connection with the community, we learned that it trigger a lot severe withdrawal among methadone patients and among people who continue to use heroin. And that was very valuable to us. And if we don't have that connection, people may just throw away the drug or drop out of treatment without us even know why. So we, because We have a team with the capacity clinical and lab and our NGO working on also on a bit on social protection, and the community. We are able to offer more than what is in that research protocol. We can take care of the people as a human being, not just as a research topic. So we become more reliable to the community, more competent. So we and that bring about the benefit for the community. So we get the evidence that it's the HIV transmission is stopped among the people who inject drug in that city. We also work on mental health, psychiatric intervention, and it's proved that it works with the community engagement. We also working on hepatitis C, and we are able to prove that among people who inject drug, it can be highly efficient and safe for hepatitis C treatment. So community benefit from that because of the work that we do together. So in all form of community engagement, I think community partnership with community participation will provide a stable continuity, because if you work with group of fixed people, people can drop out, people can be tired, people can be less engaged. But with an organization, we always have a new energy, new blood, and one support and one another. So I when it is possible, that it would be our choice of engagement with community. So this is my last slide. Just want to share with you the photo of one of many photos of our research team. The person who sits in the middle, in the black vest, the woman, is Professor François Barré-Sinoussi, the one who won the Nobel Prize for discovery of HIV virus. And she's just so proud of our project, because she was the one who facilitated this 13 years ago, and see it grow. And on the, like here you have a professor of this, professor of that, but most of the people are the member of the community organization. So I think that all of us I feel inspired and empowered. And that with that spirit, we are now working more with community in different topic. So my business cards is on the QR code if you would like to get in touch. Thank you very much.
Thank you, Dr. Ong, for the excellent talk. As we are short on time, so we need to take a break now, and all the unanswered questions will be addressed during the panel discussion. Okay, we'll be back at 11:15.
Thank you.
Thank you.